Good morning and thank you. Good to be with you again this morning. Yesterday we covered the major issue that depression has become in the Western society. We went over the definitions of depression. We also went over the diagnosis of depression. And one of the things I think you probably figured out from that is you don't have to be a psychiatrist or a medical doctor or even a psychologist to diagnose it, as long as you know those diagnostic criteria. And if you're fitting 5 of 9, or you know someone else who's fitting at least 5 of 9 of those criteria, then that qualifies as major depression. Just to see how well you were paying attention yesterday, I'm just going to ask you a couple of quiz questions. Is it possible for you to suffer from major depression but not experience sadness? Yes, it is. That's right. A lot of people think that if they're not sad, they're not depressed. But if they have 5 of the 9 of the other criteria, they might have apathy and lack of concentration and fatigue and feelings of worthlessness without the sadness, etc., then that would qualify as having major depression. And so that's one of the confusing aspects about depression. Is studies show half of the people that currently have major depression actually don't know about it. In other words, it's unrecognized. And of course, I also mentioned that you can also even qualify for that sadness criteria according to the DSM-4 criteria if you have emptiness instead of sadness. And many of the men feel empty the majority of the time, which certainly is abnormal, but yet they chalk it up as being, quotes, normal for them at that phase of existence. But they don't recognize all of the problems. Depression would be bad enough if it just did those 9 things, or 5 of those 9 things. But unfortunately, it does worse than that. Yesterday, we went over the complications of depression as far as how it increases the risk of death, heart disease, cancer, death from pneumonia. Of course, increases the risk of suicide as well. And then there are other effects of depression that are not so deadly, but certainly decrease your quality of life. And I'll refer to the screen, if you do have it on the screen. Effects of depression. Often, depression is associated with headaches. Depression has been shown in the medical literature to be associated with migraine headaches as well as severe tension headaches. And we've had many individuals who've had headaches for years and have even had to be on potent pain medicines, have seen neurologists, have had MRI scans and things of that nature to try to determine the cause of their headaches. And they're having to cover those headaches with, unfortunately, medicines that suppress the frontal lobe of the brain, like narcotics, hydrocodone, morphine, Stadol, things of this nature. And then they come to our depression recovery program. They find the root cause of their headaches is actually depression, and within 10 days, their headaches are gone, and they don't need to medicate it anymore. And so it helps to understand that many of the symptoms of which a lot of people suffer and they think is related to something else actually can be related to depression. It also causes osteoporosis. Studies show 2 to 4% more bone mineral density loss per year if you have depression. And you know, it's kind of interesting. Solomon, I think, understood that because he said, "A merry heart doeth good like what? A medicine, but a broken spirit drieth the bones." So he recognized even the effects on the skeletal system and the bones. When combined with stress, it increases the risk of HIV progressing to AIDS. One of the little secrets in regards to HIV is not everyone with HIV comes down with AIDS. They can actually have an immune system that attacks HIV at an early stage. And studies show if you have stress on board, you're much more likely for that HIV to progress to AIDS and depression as well. And so mental health can actually suppress the immune system in other ways as well. It also increases the risk of return to addictive behavior such as drinking. Now, why is that the case? Why, when people suffer from major depression, is there a higher likelihood that they're going to go back to a previous addiction? It's called self-medicating again. And so they go back to the addiction because they feel this urgent need to feel better. And of course, what ends up happening? Does that really help? No, it's a very short-term fix. It might numb their emotional pain, but now it puts them right back in that cycle of addiction, and now they have another hit on board, and it actually complicates things. But it also underscores the need to treat depression promptly and not just put up with it where these types of behaviors start to manifest themselves. It increases problems with anger and hostility. And so many of the relationship issues that our human population suffers with really have at the core mental health issues. And we can actually get along far better when there isn't depression or anxiety on board. It increases the risk of developing asthma. Asthma is increasing in the Western world significantly in parallel with the increased risk in depression. And so it even affects the bronchial tubes in the way we breathe. It increases the chance that your offspring will suffer not only depression, but physical medical problems. And so one of the most rewarding things that we have in our treatment-resistant program is often we're treating young mothers. And as those mothers' depression clears up, guess what happens? Their whole family gets better. Their kids get better. And a lot of the emotional and physical problems of their kids get better. Of course, their husband gets better, etc. And you might be familiar with the saying that if mommy ain't happy, there ain't nobody happy. And in reality, that's often true. And so that's why it's, again, important to not have these young mothers think that this is their lot in life or this is what they're going to have to go through for the rest of their life. There is indeed help beyond just the traditional types of treatments. It increases your rate of decline in physical abilities with age. Whether you end up in a nursing home or not, or how incapacitated you become as you age, has much more to do with your mental health than actually your physical health when you age. And so this is also an important fact that we need to consider. It increases stress hormones. Is that a good thing? It actually is not a good thing. When cortisol levels go up, there's some bad things that happen to the immune system. It even increases your risk of stomach ulcers. It increases your risk of memory decline. The higher the cortisol levels, the less the brain is able to function and concentrate and remember things. And so we like to see those stress hormone levels low, not high. And it decreases sex hormones. Now, this may or may not be a good thing, depending upon the individual and the circumstances. But in addition, it suppresses the immune system significantly in the ways that are mentioned on the screen. And on top of that, as I alluded to earlier, it decreases memory. And this is something that's well documented in many studies. The longer the bout of depression, the more severe the depression, the more the memory goes down. And we've had many individuals actually misdiagnosed with dementia or Alzheimer's disease, early Alzheimer's disease, that actually did not have that. They had depression. And just a couple of programs ago, we had a lady in her 50s that lost her job due to her memory. And her memory was so bad, she couldn't even find her room the first few days that she was there. But we had done screening. You know, anyone who comes to our program, they go through an extensive questionnaire over the phone. And we were convinced that this was not the typical Alzheimer's dementia based on the pattern that it had. We thought that it was a high likelihood that it was actually due to depression. And sure enough, within 10 days, not only did her depression clear, but her memory started to improve. And now it takes longer for the memory to come back. But within a couple of months of staying on the program in her home environment, her memory returned. She was able to get her job back, and everybody was amazed at the marked difference in memory when her memory had become so poor simply as a result of the depression. Now, on top of that, depression would be bad enough if it just did all those physical things, but it also does some financial things. This is something now that's been studied and published just recently. But the average person with depression loses almost 6 hours of productive work per week. In addition, 80% of people with depression in the workforce are impaired in their daily functioning. They have less ability to concentrate, lower efficiency, less ability to organize their work. They're over twice as likely to take sick days compared with people who are not depressed. And in one study, the cost of absenteeism were directly related to having an antidepressant medicine. And that underscores something else. Yesterday, I talked about one of the side effects of antidepressant medicines when you first start taking it. Do you remember what it was? It increases what? Impulsivity. And as a result of it increasing impulsivity, what else does it increase at first? Some of you mentioned it, the risk of suicide, because suicide is often an impulsive act, and that's why they have these big black box warnings. They're saying, watch out, you put the patient on this and you might tip them over the edge and they might actually commit suicide where they wouldn't have had you not put them on this antidepressant medicine. And of course, that's a difficult risk to be able to juggle. You know, how do you juggle that benefit risk sort of thing? And so, but there's also another prominent side effect of the antidepressants. And that prominent side effect is they cause an I don't care attitude in general. So if you have a person with depression, and now you add I don't care to it, they're more likely to call in sick because they don't care. And so that's what goes through their mind. I'm not feeling well. You know, I really should show up to work, but who cares? I'm going to call in anyways, et cetera. And so in that study, it actually showed that you're actually more likely to take sick days when you're on the antidepressant medication. Depressed people are 7 times more likely to become unemployed. And of course, the reason for that is whenever there's a downturn in the economy and the employees have to be let go, the employers figure out who it is that's not functioning well. And of course, that means the depressed people are being cherry-picked and being let go. And so unemployment is something that tends to occur at a much more rapid rate in those with depression. Another study took a look at the long-term effects of psychological problems during childhood. Children were followed, I like these long-term studies, for 40 years to determine the effects of illness and psychological problems on their life chances. 7 fewer weeks of work per year, a loss of 35% in lifetime income, and a lifetime loss for each family who has a depressed family member of $300,000. That is significant. That's talking about the lost wages, that's talking about the other increase in cost, the tolls on the family. And so this plays a major toll. The personal loss on average is $10,400 per year in income by age 50 in someone who begins to have depression in their 20s or in their teenage years. And so you add that up, and that's significant just in regards to the personal loss of lifetime income. And this is why, in reality, a comprehensive mental health program to improve depression should be seen as an investment. I'll just tell you, our comprehensive program that is, of course, very, very intense and very comprehensive. We attack it from multiple ways, as we're going to be talking about. Costs some money up front. And of course, when people with depression, they're saying, you know what, I don't have money, you know, I don't have a job, et cetera. But chances are there's someone who believes in them enough, recognizes their raw abilities, and often funds can be raised. Most people that come to our depression recovery program don't pay for it themselves. There are others that believe in them that pay for it, or they will take it out as a loan, but the ones who do that talk about the gain in income that happens afterwards, and so it's a tremendous investment when you consider $10,400 more of income per year after that. These people are launched for success, and in our experience, it's even greater than that because of some of the things that we'll talk about. But in this study, the cost of the total group over one's lifetime was $2.1 trillion, which does not include the increased costs of medical care that all of us must assume. That's a huge amount in this patient population, $2.1 trillion. And it turns out, we have a lot of problems with the national debt in America, and I understand you guys are following our footsteps in regards to borrowing more money than what you have in government, et cetera. It's become an epidemic in our society of not being able to live within our means in a corporate sense. But nonetheless, there's of course multiple reasons for that. We could go into all of the reasons of the unnecessary, really it's an unnecessary debt that's out there. But just one thing would actually solve it. Even though you still have problems in a lot of other areas, the one thing that would solve it is if major depression was wiped off the planet, there would be no more national debt. And you might say, well, how in the world is that the case? Well, less medical costs. These people would actually be working. They'd be making more income. And when you make more income, what happens? You pay more taxes. And there's more revenue coming into the government. And there's far less expenditures coming in. And so you could simply actually solve the national debt issue by solving the epidemic of depression. Well, in the classic book, Ministry of Healing, there's a chapter called Mind Cure that's good to get out at times. It's still a book that's far ahead of its time. But this is something that she was heavily criticized for in writing this in 1905. She said, "The condition of the mind affects the health to a far greater degree than many realize. Many of the diseases from which men suffer are the result of what? Mental depression." And again, she was criticized that. There had been no studies that have been done at that point. And now there's voluminous studies showing indeed so many physical diseases actually come from, the origin is there in the mind. She said grief, anxiety, discontent, remorse, guilt, distrust, all tend to break down the life forces and to invite decay and death. Well, she's not being criticized for that anymore. In fact, you'll be able to learn a lot of other cutting-edge things by reading that chapter in the Ministry of Healing. Well, as I mentioned yesterday, when I began to extensively study depression, I recognized that something was missing. Often what took place is the patient was diagnosed with depression, and the next thing that happened is an antidepressant medicine was being filled out. And if the patient was seen back and it didn't help, then what happened next? Anyone want to guess? The dose was increased. And then if that didn't work, then what else happened? Another medicine was added. And so often these patients were on 3 and 4 different medicines, high doses, et cetera. And if that finally didn't work, then what happened? They were referred for psychotherapy and counseling. And then if that didn't work, then what happened? Often they began to feel hopeless, or they were referred for what's called ECT, electroconvulsive therapy, where you do the induced seizures under general anesthesia, and of course you suffer the complications of that as well, which is permanent loss of past memories in certain random spots in the brain where these past memories are found. In fact, I'll just tell you, that's where we end up getting a lot of our patients. They've been referred to ECT. And often they've been told that the doctor is going to tell that they're permanently disabled or they have to get ECT, one or the other. And so they go on permanent disability, which means they're totally on government sustenance. Or if they want to have a chance of working again, they're referred to ECT, and then they will hear about our program. Or a relative of theirs will hear about a program and say, there is another alternative. And it's of course gratifying. We'll show the results of the program. But back to where I was at when I was doing the research. I recognized that there wasn't being a workup done to find out the cause of the major depression in the individual. And as an internal medicine physician, I saw it akin to seeing a patient with swollen feet and diagnosing them with swollen foot syndrome and sending them out the door with a diuretic medicine to get rid of fluid. Now, will I have cured that patient from swollen foot syndrome by doing that? Will I have helped the patient? Maybe or maybe not, depending upon the cause of the swollen feet. What is my highest likelihood of getting a cure for a patient with swollen feet? Find out the cause. And there's lots of different causes of swollen feet. It can be due to a heart problem. And if it's due to a heart problem, it can be due to 4 different categories of heart problems. It can be due to a valve problem or an artery problem or a muscle problem in the heart. Then it may not be the heart at all. It could be the liver. It could be actually even the lungs. It could be the kidneys. It could be the lymphatics. There's a number of different causes of swollen feet. And so when an internal medicine physician sees a patient with swollen feet, the first thing he does is not write a prescription for a diuretic, but to work up the patient to find out the actual cause of the swollen feet. And then there's a much higher likelihood that the individual is going to be cured from the swollen feet. And what I was noticing is this wasn't being done for depression. It wasn't being done for anxiety. A diagnosis was made and a prescription was given, and no one was really trying to determine the underlying cause. So the first thing that I did as an internal medicine physician is I thought, well, let's go to the university libraries and find out how many causes have been identified for depression. And, in the Psychiatric Bible, even today's edition, the DSM-5, it will say that with depression, there's no obvious cause. But it will talk about one cause that needs to be excluded, and that's a thyroid problem. Because if you have hypothyroidism, it can mimic depression. And so they talk about excluding some causes of it, but in reality, that's just the one cause. And so if the psychiatrist did a blood test, they did a blood test on the thyroid, and that was it. And that was the extent of the workup. And so I was expecting, due to what the Psychiatric Bible was stating, that I might find 6 or 8 causes. I figured a lot of people hadn't been studying this out, and so maybe I'll find 6 or 8 causes of major depression out there that we can at least exclude those, or at least see if those are active, and if those can be reversed, etc. And so I went to the university library and I started looking. And what I would look for is anything that at least doubled the risk of depression. And I'll tell you, I began to get depressed myself when I listed cause number 71, and I wasn't through yet. And I thought, wow, there are lots of causes out there identified. And when I got to cause number 71, and I began to experience that, when is this going to end? And when am I going to be through? This is a lot of research. I began to categorize those 71 causes, and I found out that they could be categorized, most of them, into one of 10 categories. I ended up finding over 100 different identifiable causes of depression. But what I found is the brain is pretty resilient. You can have one of those causes, you can even have 2 of those causes on board, you can have 3 of those causes, and you still won't experience depression or anxiety. But once you have a 4th category of cause, that tips the brain over the edge, and that's when the mental health issues begin to surface. And so, as mentioned, found myriads of causes, well over 100. Most fall into one of 10 categories, and depression is most often a what? Multifactorial disease, not a single cause. And we look for 4 categories of causes. If we don't find the 4th category, we have to work further, because the brain had, as part of its creative element, we talked about the wonderful aspects of the brain yesterday, but part of that is resilience. Much more resilience than what your computer has. Much more resilience than what the space shuttle has. And so as a result of that resilience, we do look for 4 categories of causes. And if we reverse those categories, of course, the depression is cured. We can actually talk about the cure word for depression. You know, when I first started talking about that, I was criticized by some in the psychiatric community. You can't talk about depression and cure. You know, it's a lifetime issue. They're going to have to take these medicines to correct their chemical imbalance for life, etc. Why are you using the cure word? Well, we're using the cure word because once we get to the underlying cause, the patient will be depression-free and anxiety-free without medication. They won't need the medicine. They won't need lifelong counseling. They won't need those type of things. And so that's when we can start utilizing the cure word. Now, as a result of hundreds of patients that are treatment resistant that have gone through our program, nobody is criticizing the cure word now because it's very clear. Let's get into the most common treatment before we get into these 10 categories. Antidepressant medicine is the most common treatment for depression. And this is what the drug company data shows. So if anything, it's weighted towards the medicine. And in fact, one Harvard researcher published a study a couple of years ago where he mentioned that the drug companies only publish the studies that show benefit. And if they actually published all the studies, we wouldn't see as much benefit as what are attributed to medicines. But nonetheless, this is taking a look at the studies that show benefit. 70% of patients will experience an improvement in their mood or other symptoms as a result of taking antidepressants. But less than 20% of patients actually no longer qualify as having depression on their antidepressant. So less than 20% of patients on antidepressants feel they are cured or back to normal while taking the medicine. The other side of the coin is this: 25 to 30% don't improve with any medication. And this is one of the things that kind of hits me when I'm dealing with these treatment-resistant patients. I'll notice, as I mentioned earlier, that they're on 3 or 4 different drugs. We'll measure the severity of the depression. We're having them go through an exhaustive, comprehensive analysis of the brain and their levels of depression. And we'll find out it's severe, about the most severe that you can get, major depression, and on 4 different antidepressant drugs. And I'm thinking, I wonder if the doctor ever considered that this patient might be treatment resistant. In other words, no medicine on the planet is going to help them. And in reality, those people often can get off of medicines pretty quick because obviously it hasn't helped. They're still at the most severe levels, and they're on all these drugs, and they're experiencing side effects of these drugs. So often, sometimes we're able to take them off too right away. We have to do it, of course, carefully. I don't want to give the credence that this can be done indiscriminately without the care of a doctor who knows what they're doing in withdrawing medicine. And your program, some of you are attending a training program in the afternoon, a mental health education program. And of course, that training program doesn't give you the authority to stop people's medicines or things of that nature at all. You're being trained to utilize the mental health information to help the people come into your community and to be a coach for them. But it's not that way. You do need a doctor's care. But 50% report bothersome side effects from medicine. That's what the drug company data shows. Over 1/2 of these quit taking their medication. And often they don't even tell their doctor because they think the side effects are worse than the disease. 2/3 are not very satisfied with their treatment when they're interviewed, and 75% on medication state that depression continues to impair their social life and their work performance as well as affect the family life. What is being very clearly demonstrated in the medical literature, utilizing the drug company data that they provide, is that medications have their limitations. Medications are not a cure-all for depression, and they have significant limitations. They can do some benefit in some cases, and as a doctor, I will actually utilize certain antidepressant medicines in certain cases, etc. And so it is a tool that's available, but it is a tool that clearly is overused, and also it's a tool that is often used that if we didn't have it around, we would be thinking of better alternatives sometimes of actually treating the depression besides just medicating it. And so this is what it looks like behind closed doors. Both mother and daughter with depression, both of them on antidepressant medicines, still both with significant relationship issues. Then we get into relapse rates. Those who discontinue usage after 3 months have a 77% relapse rate within 2 years. Another study showed a 40% relapse rate within a year, and even those who continue their medicine have a 20 to 40% relapse rate. And of course, this is when things get discouraging. First, the medicine seems to help, and within a year, 20 to 40% are back to as severely depressed as they were before, and now they're on medicines. And they may be even on high doses, and now they're starting to get frustrated and say, wow, what can I do now? And of course, that's when more medicines tend to be added and higher doses, et cetera. Well, let's get into the 10 major categories of causes for depression. And one of the things I would like to have you remember in this presentation is depression always has a cause, and we need to search for the cause. For those of you going through the training program, you probably learned yesterday. I wasn't there. Paula, of course, does a great job in putting on our training program, and she'll be doing it again this afternoon. But in the training program, one of the very valuable things they get from coming to your mental health education program is for the first time in their life, they will take a screening test to see what causes might be operative in them. And so they'll be able to realize causes that can, and many times, be easily reversed, and thus the disease be easily reversed. Cause number one is genetic. Now, this is one that is overstated in society. And to just demonstrate this, it's overstated by physicians and psychiatrists and psychologists as well. A couple of years ago, I was asked to give a lecture to a large group of psychiatrists and psychologists in Germany. They were having a major summit just on the disease of depression. It was a 2-day summit, and in the morning there were plenary sessions, and then in the afternoon there were workshops where they could go to multiple different workshops of their choosing. And my talk was on that first day at 11 o'clock. Now, I was at a little bit of disadvantage. I was the only presenter that did not know German, and I was also the only presenter that was not a psychiatrist or psychologist. And so not knowing German and recognizing these presentations were going to be in German, I didn't come at the beginning of the program when it opened up at 8 o'clock, but I thought, well, let me get there a little bit ahead of time just to get the flavor and see what's going on. This was an audience I'd never spoken to before, a professional audience and a foreign one. And so the talk that was being given that day, right before my talk, was by a psychiatric geneticist going over the genetics of depression and some of the new discoveries on the genetics of depression. Now, whenever genetics are talked about and an illness among a group of doctors, there tends to be a lot of enthusiasm and hoopla about these discoveries. And at the end, this psychiatric geneticist got a standing ovation from the group. And I should ask, why is it that doctors tend to be thrilled about new discoveries in regards to genetics of illnesses? Well, it's basically pretty simple. The idea is if we understand the genetic defect a little better, we might be able to develop a pharmaceutical agent that goes against that defect and somehow bring about a cleaner or a better cure or reversal of the problem. And so in general, it's due to altruistic reasons, we're discovering more about the genetics, and this is great, and maybe it will lead to greater discoveries in the future. Now, having said that, there's some other things that we could discuss. We could give a whole lecture here on genetics. There are 22 separate genes that have been identified as being associated with depression. But one of the things that often is not known is those genes do not have to be expressed. lifestyle actually expresses those genes. It's what we call epigenetics. And so you can have genetic flaws that are never expressed if you're on an appropriate lifestyle. But with that aside, with the epigenetics argument aside, it was my turn to speak, and my lecture was on lifestyle treatments of depression. And so I took advantage of the fact that I was not a German and not a psychiatrist, and so I played dumb at first. I just stood up and said, you know, I'm aware of the statistics in America. I'm not aware of the statistics in the German-speaking countries in Europe. And although this summit was in Germany, there were people from Switzerland and the Netherlands and Austria, et cetera, you know, the German-speaking countries there. And I said, is depression going up or going down in the German-speaking countries? What do you think they said? It's going up. I said, is it going up a little bit or is it going up a lot? What do you think they said? It's going up a lot. And I said, the only way we can explain the rapid rise in depression, and it be due to genetics, is if people with depression are remarkably more reproductive than people without major depression. And of course, they smiled and laughed at that, because you know what the statistics show in regards to depression and reproductivity? Does it go up or does it go down? It actually goes down. I talked about the sex hormones being down, relationships being down, you know, anger, irritability, those issues. And so if we're just basing this on genetics and Darwin's evolutionary theory, we shouldn't have to do anything about depression. We should just have to wait a few generations and it will be all wiped off the planet, simply because of the role that less reproductivity plays in regards to depression. And so I said the reason why depression is increasing actually has nothing to do with genetics. The genetic defect is decreasing. The reason why depression is increasing are due to other causes of depression. And I also, of course, mentioned the data as well, that genetics is never a sole cause. But unfortunately, this is what patients are often told when they're given an antidepressant. You have a genetic defect. Your mother had depression. You have a genetic defect. You have a chemical imbalance you were born with, and thus you have to take this drug for the rest of your life. And in reality, yeah, they might have a genetic defect, and certainly they have a chemical imbalance. I'm not going against that statement. We'll talk about the reasons for the chemical imbalance, but often those chemical imbalances have virtually nothing to do with genetics, and they have things to do with other causes. So just recognize there are two categories of causes that tend to be overblown in our society and way overstated, and genetics is one of those. The second cause is developmental categories of causes. Now, developmental has to do with how you were raised and some of the things that happened in your upbringing. And again, you might have bad genes and you might have a bad upbringing, but that's still not enough to cause depression. You have to have how many categories? 4 categories. The third cause is lifestyle causes. Now, under lifestyle, we have things like regular aerobic exercise. If you're not on a regular aerobic exercise program, you actually have a lifestyle hit. We call these hits or blows to the brain. If you're not regularly being exposed to fresh air, that's a hit. If you're not regularly being exposed to bright enough light, sunlight or outdoor type of bright enough light for at least 30 minutes to an hour a day, that can be a lifestyle hit. And so obviously those things are starting to occur with increasing prevalence, with people being, kind of conglomerated into cities where there's not a lot of fresh air, where exercise has become a thing of the past often. People don't necessarily have to exercise to be able to get around in society. They can go from their house to a box that takes them to their work and walk a few steps into their work and then do that reverse when they go home. And virtually not have to exercise. Now, just walking 5 minutes to work doesn't qualify. It does have to be that regular aerobic exercise, and we'll talk a little bit more about that. Number 4, circadian rhythm. This is a big one. Many people with depression have circadian rhythm hits. This is their daily sleep-wake cycle. And this it tends to be prevalent in about 80% of the patients that come to our treatment-resistant program. Addiction. It doesn't really matter what the addiction is, but if you are addicted to something, that's a hit. Not enough in and of itself to cause depression, but certainly combined with others can do that. Nutrition. This is one of the most overlooked causes of depression. Many people, even psychiatrists and psychologists, don't recognize that what you eat does get turned into neurotransmitters. It's critically important in regards to brain chemistry. And this is one that tends to be quite prevalent as well. And so just altering the way we eat and getting on a better diet can improve brain chemistry significantly. The seventh category are toxic causes. One of the toxins that's increasing in our society today is mercury. Mercury does produce some significant adverse effects on the brain in regards to concentration and fatigue and apathy and these types of things. And there can be other toxins as well. Lead is one of those toxins. Arsenic can be another. And bismuth can yet be another. And then this one tends to be overblown. These are what we call social causes. And I'll just tell you, the assumption in society today is if you have depression, you have bad genes, so cause number one is often reached for right off the bat, and then cause number 8 is reached for. But in reality, less than half of my severely depressed patients have a social cause. They all have social complications. But what happens is when they are diagnosed with a social cause and they don't have one, the psychotherapist is trying to manipulate their home life, their family life, their relationships, and none of those need to be manipulated at all because they're not even a cause. And of course, that tends to make things worse. And so often the depressed patient is turned against the very loved ones that can help them out by misidentifying the actual cause of depression. And so our questionnaire that has been developed, that we give to every patient that comes to our program and that you will give to the patients that come to your mental health education program, is we've developed a questionnaire to be able to identify if there is a social hit or if there isn't a social hit. And so what we look for are really the social isolation types of things that are, of course, associated. Number 9, medical conditions. Now, there's a number of medical conditions that can play a role. Hypertension actually is one of those. Previous head trauma is another one. Encephalitis can be another one. And an autoimmune disease such as lupus, etc. Previous strokes to the frontal lobe of the brain. And so we look for medical causes that can be associated. Of course, thyroid, we mentioned that earlier. And there's a whole list of medical conditions that can do it. And there's a whole list of medications that can also do it. I was with one of your leaders of the British Union yesterday, and he was mentioning how he became severely depressed over taking a medicine actually to try to prevent malaria when he goes down to Africa. And they didn't know what it was due to, but after time it became clear that the larium had tipped it over the edge and caused significant depression. And so we go through the list of medicines and look at that as well that might be actually inducing depression. And then the 10th hit category are frontal lobe causes. And this is one of the causes that has also increased significantly in our society. Diets in general have gotten poorer. Lifestyle causes have gotten much more prevalent. Circadian rhythm causes have gotten much more prevalent, and as well as toxin and addictions and frontal lobe causes. Now, frontal lobe has to do, the frontal lobe is the seat of spirituality, morality, and the will. And it's the analytical portion of the brain. If we're not regularly engaged in abstract thought, on contemplation of spiritual themes, or if we are participating in entertainment that suppresses the frontal lobe of the brain. Certain types of music, the syncopated rock and roll music, if you listen to that for any syncopated rock and roll piece for 90 seconds, the frontal lobe starts to go down. You'll see this on EEG, etc. And so a lot of the so-called charismatic music that tries to get people animated actually is somewhat like a drug that can make them feel more animated, like drinking a glass of alcohol or two can, but in reality sets them up for frontal lobe suppression. And one study at Duke University showed the most likely group of religious people to experience depression are the charismatics. Depression rates are very high among that group. There's also other types of entertainment. The rapid scene of reference of entertainment, television, etc., can suppress the frontal lobe of the brain. And so we have a questionnaire that deals with many of those aspects to see if a frontal lobe cause is prevalent. And again, we'll have people with major depression that come to our program. Of course, we're dealing with the more extreme end that come to our program. But some of them will have 8 different categories that are active. Sometimes 9 different categories that are active. Very rarely do we see someone with 10. We had someone in our last program that had all 10, but that's not near as common. But fortunately, 8 out of those 10 can be reversed in most cases. And if we reverse those underlying causes, we see dramatic improvement and rather rapid improvement. You would be surprised. You know, in the medical literature, it states that when you're on an antidepressant, expect 6 weeks before you start noticing a significant improvement. None of these pharmaceutical studies will they measure it 1 week later, because the drugs would not be shown to be effective at all then. So it has to be quite a period of time that's afterwards. And one of the things that was surprising even to me is once we started this program for depressed people, we were seeing dramatic improvement in less than 10 days, about a week later. And then within 10 days, things started to really ramp up. And by 19 days, even that much further. And so it can, when we remove the underlying causes, the brain can start to recover much quicker than what has been previously described in the medical literature. Well, let's go over a couple of these before our close today and some more details. The developmental hit, if you're not being raised by both biological parents, that actually is a developmental hit. And it doesn't matter necessarily the reason. But you know, in today's society, I don't know what it is in Great Britain, but do you know what it is? Anyone want to guess in America what percentage of young people today are being raised by both biological parents at the same time from birth until they're an adult? It's about 20%. 20 to 25%. And so the vast majority of kids are not being raised by both biological parents. Of course, a lot of births occur out of wedlock, but in addition to that, there are many divorces that also occur. And when divorces occur, I don't know, again, what it's like in Great Britain, when divorces occur, what often happens is the children are being shared from one parent to another. Maybe they're with the mother on the weekdays, and then they're with the father every other weekend, and maybe every Wednesday, etc. And so the parents then begin a competition to see who can be the most popular parent to the young kids. Because they know when those young kids each reach a certain age, say 12, 13, or 14, they can go to the judge and say, I only want to live with dad. I don't want to live with mom. And the judge will say, well, if that's who you want to live with, we'll let you live with dad. And so as a result of trying to become the most popular parent, does that make them actually the best parent? Absolutely not. And so often these kids are shocked when they become adults and in real society have to perform functions in a job and then think their employer is austere and mean and all of these things, and it's simply because they've never been raised with any discipline because of the competition that's going on. And of course, it really significantly impairs their own ability to perform, and it does result, of course, in that developmental hit. History of depression in adolescence is also an issue. If you've had depression younger in life, that's a clear sign of a developmental hit. Sexual abuse. And the sexual abuse, of course, can occur in young boys and it can occur in young girls. That can also be a significant a setup today. I'll just tell you one of my concerns in society today. We could deal more with this later. Well, I'll just come out with it now, even though normally I try to develop it more, but I recognize that we may have a more educated audience in this regard. And so I'll just come out with it in regards to this. But one of the myths, and I could present this, there's a whole lot of data in regards to this. One of the myths that society believes in as a fact is that homosexuality is not a choice, it's what you're born with. But in reality, studies clearly show that homosexual behavior in many cases is because of recruitment of other homosexuals. In other words, the person was a heterosexual, and studies show if you take a heterosexual male and you give them a homosexual experience, they'll be bisexual in one a sexual experience, and by their third one, they'll be exclusively homosexual, no longer interested in heterosexuality. And often what happens is homosexuals are also known to be far more promiscuous. The average number of different partners in 1 year among a homosexual is 13. And so far more promiscuous even than the average adulterer heterosexual individual. On top of it, after the time of continuing to recruit, there is a stronger tendency for them to recruit young boys. And in today's society, I don't know how it is in Great Britain, but right now in America, if you put your kid up for adoption, which if you are not set up to raise your kid, that's a good thing to do, to put them up to adoption. But in America today, you cannot specify whether that person will be raised by a heterosexual couple or a homosexual couple. And in America, 50% of kids are being adopted by homosexual couples so that they can feel, quotes, normal, etc. But this does set them up, and I think the evidence is clear, for a much greater risk for a developmental hit and actually being taken advantage of in certain settings. History of alcohol or illicit drug abuse as a teen is also an issue. And so if you've had alcohol or illicit drug use early on, that's a developmental hit. And then there's nutritional development. And I'll just leave it at that. We could go into a discussion of that. But if you're on poorer types of nutrition at ages 3 to 5, particularly if you're a girl, you're much more likely to develop early puberty. And if you start menstruating before the age of 11, that's clear that you are set up for that early puberty, and early puberty also increases the risk of anxiety and depression, as well as breast cancer and other types of issues. And so we don't have to have early puberty. We can delay puberty by getting on a healthier diet of young girls, particularly between the ages of 3 up to 5. Well, in regards to lifestyle, this was an interesting study. 96 patients were randomized to receive light therapy plus a placebo capsule or placebo light therapy plus Prozac for 8 weeks. Clinical response rate in each group was what? 67%. You know, often we'll just see one simple modality, light therapy, compared with a standard antidepressant, Prozac, and then see equivalency of a simple natural remedy, light therapy. And notice, further analysis indicated that light therapy provided a quicker initial improvement. So just light on its own will produce a 67% clinical response rate. And you know, one of the things I had to tell my audience, I might just, we'll mention this text and then I'll close with this story. Solomon also recognized this. He said, truly the light is what? Sweet, and a pleasant thing it is for the eyes to behold the sun. One of the reasons for some of the increased risk in depression in Great Britain is simply because you don't have a lot of sun necessarily here. That's one of the issues in the northern part of the U.S. The northern part of the U.S. doesn't get as much sun. We call the southern part of the U.S. the Sun Belt. And not having as much sun, or if you are out in a cloudy day, it requires you to be out a much longer period of time to get the same benefit through the eyes. The benefit is through the eyes in producing serotonin levels. But one of the things I should mention in my talk a couple of years ago in Germany, at the end of my talk on lifestyle treatments for depression, among this group of psychiatrists and psychologists, I was anticipating, like I give it in most audiences when I open it up for questions, there's a lot of good questions. So at the end I said, any questions? It was just quiet. One man in the back finally raised his hand and asked a rather simple question, and I clarified it, and then that was it. No response. And I was thinking, wow, what happened? And then in the afternoon I had a workshop on lifestyle treatments for depression, and 2/3 of that audience went to my workshop. I felt sorry for the other presenters that were there, but even though they had no response, they were curious enough to come to the workshop. And then in the next morning, I was giving one more plenary session. And I asked a psychiatrist from Johns Hopkins who was German. He had trained at Johns Hopkins in Baltimore, Maryland, but he was practicing in Germany. I said, what happened yesterday? What was that? And they said, well, they're not believing the clinical response rate that you mentioned at the end. They think your data or your numbers are somehow cooked because they've never seen results anywhere close to this. And I thought, okay, well, at least I know where they're coming from. And so I rearranged my slides to show a number of therapies of what we call reductionist therapies. And this slide here is a reductionist therapy. Reductionist means you only make one change, like putting a person on a medicine or putting someone on light therapy. Then I showed them another reductionist therapy, putting them on adequate amounts of omega-3. That even does a better response than light therapy. Then I showed them another reductionist therapy of putting them on the right type of music therapy and showing the benefits there. And I said, what's different about our program is others have done reductionist types of therapies, making only one change. What we're doing differently is we're leaving no stone unturned, and we're doing it in a comprehensive way for the individual patient based on their needs. And it shouldn't be surprising that we're getting results far greater than 95% when we do it in a comprehensive way. Cognitive behavioral therapy improves it in about 57% of patients, but on its own, only 57%. By the way, in that medication study, the medicines only did 57% as well, so it was equivalent to medication. But the cognitive behavioral therapy, when combined with a comprehensive program, does far better than 57%. Once we get the frontal lobe active where they can understand the cognitive behavioral therapy, which we'll be getting into later on. And so I think it is encouraging. The biblical principles and the principles that science has illuminated in reductionist sense, when we use it in a comprehensive sense, can produce a transformation that is unprecedented. And so spread the news. Depression is not something that has to be lifelong. It's not something that has to be tolerated for very long. There is a cure. And it's important for the individuals to get to the real underlying cause. And tomorrow we will be discussing a little more aspects of the hits that are there. I want to spend a little more time into some of these prevalent hits that are there. And then we will also spend more time on nutrition in the brain, not only in regards to depression and anxiety, but also in regards to peak mental performance. And so I look forward to seeing you tomorrow morning. Let's bow our heads as we close this session. Father in heaven, we thank you for the interest that you have in our bodies, minds, and souls. And we thank you for pointing out the way, even in little detailed ways, on a better way to live. We recognize that your desire for us is to not only have life, but to have it more abundantly. And we thank you in Jesus' name. Amen.